نقدر نبتدي دلوقتي السكند سيشن. طبعا بنهني طب عين شمس بنجاح المؤتمر، وبنشكر الدكتورة منار على الدعوة الكريمة للجيرياتريك سيشن. عنوان السيشن The Power of a Smart Solution in Effective Chronic Disease Management. First هنقدم الدكتورة إيناس هتقدم the first speaker. اتفضلي دكتورة إيناس.
It's my pleasure to present my eminent Professor Raif Malek, his presentation about the smart technology for managing diabetes in the elderly.
صباح الخير. أشكر الأستاذة الدكتورة هالة سويد، وأشكر الأستاذ الدكتورة منار مأمون على دعوتي للمشاركة في المؤتمر في السيشن الهام جدا، وأشكر الدكتورة إيناس على المقدمة الكريمة والبانيلست. وأحب أتكلم في دقائق بسيطة عن بعض الإضافات اللي دخلت في دنيا الديابيتس وخلت الاوتكم اوف ديابيتس افضل من زمان واسهل من زمان. طبعا الجزء التشالنجينج للجميع هو جزء الانسولين ديبندنسي، ورغم ان ده كاركترستيك للديابيتس in children، لكن the other most common group يعوز الانسولين هم برضو الالدرلي لسببين. السبب الاولاني انه في elderly people who do develop type 1 diabetes from the onset، والسبب الثاني انه اذا كان الديابيتس تايب 2 بيبدا في age 40 50 for the elderly in their 60s 70s and above. By that time they have been type 2 diabetics for 10 years or more, at which time beta cell reserve have been depleted and they do need insulin. When we add comorbidities والسيرجريز والأورجان ديزيزز المختلفة، السيكتور كبير من الالدرلي هيحتاج انسولين. اللي خارج من هارت اتاك، اللي خارج من اوبريشن، اللي عنده كدني ديزيز، ليفر ديزيز، سيرجريز، حاجات كتيرة جدا، ويكنس، ساركوبينيا. واحد الميستيكس في علاج الديابيتس في الالدرلي ان انا اتعامل معاه زي ما بتعامل مع الادلت at age 40 or 50. فبنشوف elderly people في سن 70 بيتكتب لهم SGLT2 inhibitors، اللي هو الدواء الجديد اللي بينزل السكر في البول وبيفيد القلب وبيفيد الكلى، ومش واخدين بالنا انه الادويه دي بتعمل ساركوبينيا، بتقلل المسل ماس. For an elderly patient with a limited mobility, sarcopenia is a major problem, and these are not the best medicine for the elderly. For the elderly, diabetes is needed. My previous speaker, Professor Hills, was kind enough to end his lecture with a note about the diabetes patch, which we call the sensor. And from that point, we take on. The diabetes patch or the sensor is a great addition for management of diabetes. We usually look at beta cells as organs to secrete insulin, and actually they do have another job which precedes secretion of insulin, which is measuring blood glucose. So beta cell cannot secrete insulin blindly. It has to measure blood glucose with a specific enzyme called glucokinase, and this is the glucose the only tissue, the only cell in the body which is able to secrete insulin. What's good for that? It secretes insulin as needed. From the discovery of insulin in 1921, we all saw diabetes as replacing insulin. How much insulin? How many times to give insulin? Previously, history evolved from testing the urine by Benedict to dry chemistry to glucometers, but now there are the sensors, and we have the sensors. The advances in diabetes and preventing complications mainly came from self-monitoring. So nephropathy, from a prevalence of 30 to 40% to type 1 diabetics in the 70s, it decreased down to 10% in the 90s and the early 2000s. The only technological advance at that period was the invent of the glucose monitoring, self-glucose monitoring, and it's becoming available to different people. Now we have the continuous glucose monitoring systems, which is a sensor inserted to the skin. It has this very thin fibril. It measures blood glucose. It sends the signal via Bluetooth to a measuring device or to an application on the phone, and it gives a continuous view. And this can be combined with an insulin pump, creating the artificial pancreas. The challenge is the cost, because diabetes is a disease of disparities. Only the rich will be able to buy the latest insulin, will afford a 4,000 pounds sensor 2 times per month, will afford an insulin pump. Countries do baffle with themselves how to cover the costs of diabetes, and that is the problem. Our country is making very good steps in that, and lately, at least for children, it has been approved that children below 18 will be able to get the glucose sensors for free as far as they are insured by their usual domestic insurance policies. So countries are trying to cope up with the costs of diabetes, and for us in Egypt, it is working and it is getting better. These recommendations by the NICE guidelines issued every few years from the UK have recommended that not only the children with type 1 diabetes should be monitored by continuous glucose systems and sensors. Any adult using insulin intensively, any adult who is dependent on insulin should also be given, should have the sensors as the standard of care. And this is their statement: adults with type 1 diabetes should be offered the choice of a real-time or intermittently scanned continuous glucose monitoring system. For the geriatrics with diabetes, we have special problems. We have the problem of accumulation of morbidity. When I'm seeing a child with diabetes, I'm concerned with diabetes. For an elderly, we have diabetes, hypertension, cholesterol, heart disease, kidney insufficiency, liver disease, fracture, osteoporosis, immobility. Accumulation of morbidity comes with polypharmacy. With polypharmacy, there are so many drugs interacting together, and the most common presentation we see is an elderly patient taking a sulfonylurea since he developed diabetes at age 50, going on the same dose, and by the age 70, he is still using the sulfonylurea that he started 20 years previously, but 20 years on, he has a reduced renal clearance and starts developing hypoglycemia, sometimes up to coma or leading to behavioral disorders. So with polypharmacy comes drug interactions, kidney interference. For the elderly, they are dependent on caregivers. One of the main problems when I prescribe insulin to an elderly patient coming on a wheelchair with very limited mobility and perhaps some mental affection, who will give him the insulin, who will calculate the dose, who will inject the dose, who will count the meals, who will follow his blood sugar. He needs almost a full-time observation if he's to receive insulin 3 or 4 times a day. Compliance with treatment for those elderly who lives alone, and this is becoming more and more a feature of the city society, that elderly people, sometimes they stay at home on their own. If they have children, they would visit them from time to time. If they are isolated, they look for a caregiver. So they start to miss the doses. He cannot take 4 injections of insulin per day. It's not a problem of he doesn't want, he cannot. We have the problem of sarcopenia. Sarcopenia is the diminished muscle mass. What happens with the diminished muscle mass in the elderly? There is insulin resistance, because muscles are the tissues which respond to insulin and consume glucose. If I have sarcopenia, I have insulin resistance. I need more doses to control my blood sugar. And for some medicines, as I mentioned, which increase sarcopenia, that would not be a good choice. We have a problem of mobility, a problem of dexterity, getting around in their own apartments, bringing their insulin from the fridge, taking the injection. There is a problem of altered pharmacokinetics, decreased kidney reserve, which is universal with aging, certainly affects the half-life of medicine. And so they develop hypoglycemia with even normal doses of medications or insulin. Aptitude and disability. And this comes So what are the advantages of using a CGM system over the usual self-monitoring of blood glucose? Imagine a patient with an A1C of 7%, which is at the borderline and is considered to be accepted for elderly diabetics beyond age 65 to 70. A patient with an A1C of 7% can have his target range within 70 to 180. This is considered the time in range, means that his blood glucose fluctuates within a range of 100 milligrams of glucose, which is equivalent to 4 millimoles and a half. So he can have all his time in the range. He can have 30% time above range and 8% time below range, and even worse if the blood glucose is fluctuating massively he can have 60% above range, compensated by 20% hypoglycemia, resulting in an A1C of 7, all the same. So the A1C does not tell the whole story. I can have an acceptable A1C, but an unacceptable glucose variability. So if a patient checks for blood sugar using the usual glucometers 4 times a day, as we usually ask from him, to check the glucose in the morning, after breakfast, at noontime, after lunch, after dinner, at bedtime, 4 times a day, and all look fair enough within the range, 120, 60, 90. But when we start using the CGM, continuous or real-time glucose monitoring, then we find that there are so many hypos and there are so many highs amounting to 250. And this is the big difference between single point measurement, pricking the finger, and a continuous or real-time glucose monitoring. At the same time, as Professor Hills have already noted, for patients using the glucose monitor, they can start realizing what kind of food results in high glucose levels, what amount of dose would cause low glucose levels, and how to navigate himself between this and that, getting into a kind of safe treatment. So glucose variability cannot be predicted from simply an A1C. And this curve shows a patient with less glucose variability, with an A1C of 7.8. His blood glucose is an average of 200. And another patient with the same A1C, but having wide swings of blood glucose, the situation that we see when we use multiple insulin injections a day for patients with depleted insulin reserve. Both have the similar A1C, but they differ in the pattern. So if you are considering to raise the basal insulin or the slow type of insulin, that would fit patient with a stable level, but will not certainly fit the patient who develops low blood glucose. These findings can only be seen with CGM. What does the CGM tell us, which does not show in a usual glucose monitoring? It tells us the trend. The trend arrow is a very important addition. The machine compares the readings with each other. So they would advise the patient that take care, blood glucose is rising rapidly, more than 20 milligrams or 1 millimole in 10 to 5 minutes. Take care, it's rising fast. Or it is rising but not rapidly, less than 1 millimole in 10 to 15 minutes. With a horizontal arrow, blood glucose is relatively stable, but it is maybe also moving, but very slowly, within 10 to 15 milligrams, less than 0.9 millimole in 10 to 15 minutes. With an inclined arrow down, it's the similar, and with a sharp decline, it's a warning. What does this do? It gives a heads up to the patient. So if he has having a rapid fall, he can take something sweet and avoid getting to a hypo. If it is going high, then it would be time to take an insulin correction dose. To summarize the benefits of a CGM, continuous glucose monitoring system, it gives the patient an insight into the effects of food. Now he can make better choices because he sees what happens for different types. It improves the time in range. It shows the trend arrows. It has audible alarms. One of the very important things is the alarm, because it will safeguard the patient from nocturnal hypoglycemia, the one everyone fears most, to develop low blood glucose at night. And diabetics do have an innate fear that something would happen and he would die while sleeping if he takes too much insulin at dinner time, or if he raises the basal insulin. The sensor has done a lot to protect the patient from that by the alarms. It's approved for children and adults. It can connect to a pump. The sensor is the major component of the artificial pancreas. It can connect with family members, caregivers, doctors. It can be downloaded to the doctor's office. It has been linked to improve the A1C with reduction in hypoglycemia, less emergency visits, and hopefully on the long-term protection from complications. These are the available systems nowadays. Guardian by Medtronic was the first to be available some 20 years ago, and Dexcom was the second. Lately, Freestyle have taken over for advantages of size and price. So the Guardian sensor is the first to be available and the first to be combined with an insulin pump, creating the artificial pancreas. It's an Irish brand. However, the sensor is bulky. It's the size of half a hand. So children don't like it. It can get snatched in clothing. Dexcom is the American brand and is the one most commonly used for insulin pumps and artificial pancreas. It comes in two parts. You can see the filament, small filaments below the sensor. This is the one which feels the blood sugar in the tissue fluid, but this one needs a transmitter to be attached. And it works only for 10 days, and so the patient needs 3 per month. The system available for us in Egypt mostly is the Freestyle, which is a British, American, German brand. It has an advantage of combining the transmitter with the sensor in one piece, and they have minimized the size of the sensor to the size of a coin, a small coin as well. Another system with a different approach is the Eversense, and this is an implanted capsule that measures blood glucose for 6 months. It has to be inserted by a minor procedure in the doctor's clinic, and a transmitter is to be available to receive the signal from the Eversense sensor.
Thanks. Thanks, Dr. Raif Malek, for this lecture, this important lecture on management of the elderly diabetic patient, especially vulnerable for recurrent hypoglycemia and malnourishment. What about the situation in Egypt for the elderly diabetic population? About the cost and real implementation in Egypt?
Yes, this is totally true. We are now advising elderly patients on intensive insulin regimens, 3 to 4 injections per day, to adopt the continuous glucose monitoring approach, though it is not insured
Yes.
now in Egypt so far. But for people with resources or for people with family support, they can have it, and it protects them from nocturnal hypoglycemia and helps a better control.
Thanks, Dr. Malek. Any question for Professor?
I'd like to ask you, Professor Raf, thank you for your lecture. What about the use of insulin pump in elderly? What's your experience about that?
Of course, this is possible. However, it is compounded by the fact that many of the elderly diabetics have insulin resistance as well, and they need large amounts of insulin per day. And so the cartridges of the pumps are not designed for that. They are designed for people requiring small amounts, so the cartridge would last for 3, 4 days, 5 days. For the elderly or for some people with obese type 2 diabetics, they do need much higher doses of insulin. But there are people who tend to use the pump. The results are not so rewarding as it is in children. It's an evolving scope of management.
Thanks.
Thanks, Dr. Raif, for your great presentation, and thanks for telling us that children less than 18 years will have free sensor.
One of the best news.
Yes, this
I
is
was so
part
happy
of
to-
successful aging. We are hoping and looking forward.
Yes, of course. I was
course.
so happy to learn those news.
Yes, we are so happy. So, I want to ask about variability in insulin levels. In old days, we had argued it is the duration that causes complication. No, it is the control which is most important. But I think variability is important as well. How variability affects complications? We have readings that hemoglobin A1C is okay, fasting blood sugar is okay, 2 hours postprandial is okay, but actually you gave an insight about the variability that we don't observe without sensor.
Glucose variability happens or occurs in a setting of a depleted pancreas. So whenever the insulin reserve is very low, there is no buffer within the body to control highs and lows. Once the patient starts using the mealtime insulin, there is definitely episodes of low blood glucose and high blood glucose. When the variability is great, the patient compromises with less doses to avoid low blood glucose, and he opts for a higher glycemia. So those with variability, they usually or eventually stay at 7.5, 8, and many times much more than that. And they can have complications, whether from the low blood sugar producing hypoglycemic events and complication, or the high blood sugar resulting in complications for the vessels over the many years of living with diabetes.
So can we use sensor without pump just to detect how
Of course,
control is?
This is what we are adopting. Every diabetologist, Professor Ines, I'm sure she agrees with me as well. Every diabetologist is recommending a glucose monitor for patients dependent on insulin whenever there is a possibility for that.
Thank you, Dr.
Thank you very much.
Next session lecture, Beyond Inhaler, Smart Thinking for Better Breathing by Professor Heba Abu Rigal, Professor of Chest Disease, Ain Shams University Hospital.
السلام عليكم ورحمة الله وبركاته. كل عام وحضراتكم جميعا بخير. Thanks dear professors and colleagues. It's my honor to be here with you today. هيبة جمال عز الرجال, Assistant Professor of Chest Diseases, Ain Shams University. My lecture today is about smart thinking for better breathing. Previous lectures talk about remote patient monitoring and many smart techniques and solutions. Here I will be concentrated about how to sync with chronic respiratory disorders. This is my agenda today about the challenges and role of smart solutions, how to deal with in chronic respiratory diseases, role of telemedicine and precision medicine, with some future innovations. Generally, the meaning of smart meaning intelligent and sharp. It may be also go related to the specificity, the measurability of the technique, how it is achievable, how it is relevant, and how it is to be time bound. All this can be applied to choose the specific smart technique you can think about. Also, smart solutions can be related to the new technology and devices now used with electricity and Wi-Fi and apps, new device. Also, to the how the devices and applications can be used in chronic respiratory diseases. Beyond how what happens in inhalers today, the combinations, the techniques, the powders used in the inhalers, and the different, even new last GINA guidelines, which were used the single maintenance and reliever therapy in track 1 treatment of asthma as a smart technique to reach a goal of diagnosis and treatment of those patients. Many challenges in chronic respiratory diseases facing us in our clinics and situations and hospitals related to the late diagnosis and poor patient compliance adherence to treatment. Also, the high hospitalization rates for those patients. Also, the limited access to health care in remote places. زي ما حضراتكم عارفين ممكن يجي لنا عيان من remote places وجاي ب complication with late diagnosis. How we be smart in thinking in this what we need to have in this situation. Early detection and monitoring, personalized treatment plans. This item about personalized treatment plans to use what available and what we can reach to help our patient from being late in treatment and diagnosis. Enhancing patient engagement and reducing hospitalization. How we can reach these goals? By early detection, treatment plans, and monitoring. First, early detection. Early detection for chronic respiratory diseases is very important, as from a good history taking and screening of our patient and searching for the risk, we can reach early the patient. Like risk for patient who was treated as asthma as long time, but he is lately diagnosed as interstitial lung disease because there is discovered risk to have, or those patients who have to bird breeding or cats or whatever in their homes, or occupation related to the risk of this occupational lung disease. Screening for those patients is very important, especially in the setting of occupational medicine. The second item is laboratory investigations. Many laboratory investigations, even simple investigation, can help to catch our patient early, like CBC. With eosinophil count, we can reach about, talk about eosinophils early. Also, many blood biomarkers now available today for those patients, like IgE, fraction of exhaled nitric oxide. Also, genetic analysis, which help in early detection and also follow up the prognosis of the disease. Simply, chest X-ray is very important in the radiological investigations for chronic respiratory diseases or disorders. The patient is treated for years as he is an obstructive airway disease, and no one only requested from him for a chest X-ray. Years. And he suddenly discovered that he has a lung mass associated with his chronic airway disease. So in these chronic situations, with those patients with high risk, we must even basic radiological investigation should be in our mind. Second is high resolution CT, and this is now not new. High resolution CT is implicated in several chronic respiratory diseases, especially early detection of interstitial lung disease. All types of IIBs, idiopathic interstitial pneumonias, mainly high resolution CT can discover. The functional assessment in chronic respiratory disease is very important. According to the available functional assessment, we can depend. In our labs in Ain Shams University, all functional assessments are available. But even simple spirometry, which is subjective, so subjective, but I can depend even on the shape of the curve. Many patients also came treated as asthma, and he has history of attacks of wheeze, but no one can differentiate this is asthma or upper airway. Simply he did the test for spirometry, and he had discovered that he has a flu or a flat flow volume curve even with normal spirometry. The shape of the curve only discovers that this patient has an upper airway disease, not lower airway disease. So we can tell that we have no diffusion lung capacity for carbon monoxide. We can't assess. No. Even spirometry can help us to detect many and early respiratory diseases. Impulse oscillometry is available for children, DLCO is diffusion lung capacity, and many others related to body plethysmography, and available many functional assessment. Treatment plans. Treatment plans is very important to assess for chronic respiratory disease patients regarding the medications he take and how to take and the doses he take. This is very important to put with the patient how to deal with this. Mainly in our set of chronic respiratory disease is the inhalers. Systemic treatment is only not so long duration. Personalized الهوم devices in chronic respiratory disease والportable devices very important, and it decrease the admission and hospitalization rate markedly. We have home devices like concentrators, oxygen concentrators in patients with respiratory failure. Also home CPAPs and BiPAPs for those patients with type 2 failure and those with obesity hypoventilation syndrome. Portable devices like compressed oxygen cylinders where the patient can go to his work with this even with, when he is respiratory failure patient. Also, he can take for pulmonary rehabilitation programs with this portable small oxygen devices. So even we took that this patient has respiratory failure, he can't go anywhere. No, he can go, he can do, he can make exercise, so he can participate in any of our work. Personalized treatment plans, and this will be specific. I'll talk about some chronic disease in the next. Prevention in treatment. Prevention is very important. Prevention of exacerbations. Prevention of rehospitalization. Those plans for prevention for many chronic respiratory diseases is very important. Prevention of exacerbations like we do in tobacco smoking programs. Also in prevention by vaccinations for those patients, pneumococcal vaccine, influenza vaccine, and nowadays even in elderly respiratory syncytial virus is added to these vaccinations and COVID. Prevention also by avoiding the risk of the patient to avoid more disease progression. Monitoring and follow-up. Monitoring and follow-up is very important in chronic respiratory disease because the patient is the he can take the treatment from the doctor and came after months. Not every month he should be on the OBC or for follow-up, coming for follow-up, because there is a written action plan between the physician and the doctor. By monitoring also his symptoms by different scoring systems like CAT in COPD assessment testing, like his dyspnea score, he must know about his disease, how to monitor, to be in a single language with his doctor to tell him about the situation. Telemedicine and remote patient monitoring. ده اعتقد دكتوره هدى اتكلمت كتير عن الريموت بيشنت مونيتورنج. والديفايسز الافيلابل ان شيست ديزيزز، هي عرضت حاجه ريليتد للسليب، بس هو اللي عرضته ده ريليتد للسليب ده يعتبر سكريننج. We can't depend on this like a smart watch connected to pulse oximeter for sleep disorder or sleep related breathing disorder diagnosis. No EEG, we can't mention what type of sleep disorder. No connection to nasal cannula or thermometer. No one can comment on apneas or hypopneas. No body belt or thoracic or abdominal belt, we can't comment about the type of apneas. So it only can be used as a screening for this patient who can go to the lab. Not all go to the lab, but he can go to the lab, sleep lab, and do full sleep study. Wearable devices as سمارت واتش زي دكتوره هدى اتكلمت عليها والافيلابيلتي بتاعتها. السمارت فون ابس فور فيزيكال اكتيفيتي، ودي موجوده فور كرونيك ريسبيراتوري ديزيزز زي اب فور COPD. My COPD, he can open classes according to the patient situation for what physical activity he can do. telemedicine and remote patient monitoring حضراتكم اتكلمتوا عليه بما فيه الكفايه واهميته في decrease الهوسبيتاليزيشن والافكتيف كير والكونتينوس مونيتورنج. وده available خلاص في يعني already done with 6 specialties. One of them is chest for our patient to follow up in our virtual clinics. Precision medicine. Precision medicine is shifting from this general thinking to a specific thinking, like in some chronic respiratory disease, as in asthma endotypes and biologic treatment was already emerging now, and already some patients are on biologic treatment, like mepolizumab and benralizumab related to the high eosinophil count, and omalizumab and dupilumab related to IgE and interleukin 4 and 13. COPD phenotypes. COPD related to the pharmacogenetics of beta-adrenergic receptor response, and some benefit from alpha-1 antitrypsin deficiency replacement therapy in those patients with alpha-1 antitrypsin deficiency, and predicting disease progression with metalloproteinase polymorphism in COPD. An interstitial lung disease, يعني interstitial lung disease, especially in the familial type and idiopathic type, those with mutations in the telomerase gene shortening or lengthening, many mutations, biomarkers related to metalloproteinase and surfactant proteins. These mutations can follow up the treatment and the response to antifibrotic treatment like nintedanib and pyrifenidone. Cystic fibrosis. Cystic fibrosis related gene mutations like Trikafta now target specific for cystic fibrosis transmembrane conductance regulator gene mutation, which already available with the pediatric hospital now with our department. Pulmonary hypertension personalized treatment related to the mutations in the bone morphogenetic protein receptor type 2 targeted treatment, and a specific treatment based on the level of insulin and level of prostacyclin to this patient targeted to insulin receptor antagonist and prostacyclin analogs. Innovations on what is new. Now في non-contact diagnostic techniques to differentiate many types of chronic respiratory diseases or respiratory diseases from the respiratory or the breathing pattern of the patient, and this by radio frequency software system connected to know the type of breathing disorder to know the disease. Artificial intelligence. Artificial intelligence help in diagnosis with us, helping the radiologist very specifically. AI ultrasound models which help to diagnose pneumonia from COVID pneumonia. CT algorithms which help to know the CT pattern images. Available softwares now is available for COPD. We did research. This is an Egyptian work done by artificial intelligence for CT with COPD patient. Or is this another one, artificial intelligence with COPD? Advances in portable scanners. Now there is available portable CT, which can go to ICU with portable workstation, wireless, and can do all types of CT, even ventilation perfusion scans and angiography. Also, many AI-related interstitial lung disease interpretations, but still software is not available today. Or AI-powered software for lung nodule detection, and this is very early detection for lung nodules. Advances in COPD treatment, and this is what is new today for biologics in COPD. Biologics can give hope in COPD patients, and this is a new era to use biologics in COPD. As in COPD foundations, they studied presence of interleukin 33 and thymic stromal lymphoprotein, which help in targeted treatment for COPD. Also, in New England Journal, now they manage about biologic of COPD. And last, GOLD guidelines also, they talk about the biologics in COPD. Also new era for asthma, inhaled biologics. This is also new in asthma. In conclusion, chronic respiratory diseases goes beyond inhalers. Even without advanced AI or costly devices, we can achieve better outcomes by early diagnosis using simple tools, by patient education and empowerment, especially about risks prevention, inhaler technique, and self-monitoring. Low-cost, smart solutions like written action plans, available mobile apps, and remote follow-up via basic telemedicine can help also. Community-based care models to improve access and adherence, particularly in remote, unserved areas. These action plans will help to decrease the number of patients who will come late to us. By focusing on prevention, personalization, and follow-up, we can reduce hospitalization and improve quality of life even with limited resources. Smart care doesn't always mean expensive technology. It means using what we have in better and more thoughtful ways. And thank you very much.
Thank you, Dr. Heba, for your presentation. Actually, it was fruitful and I learned a lot from it. But I have a question. What about smart solutions for pulmonary rehab, especially in elderly? One of the major problems in practicing geriatrics is the need for rehabilitation, and the elderly can't move or go to a rehabilitation center, and he needs assistance. And I know that pulmonary rehab now is going far. What about our situation in Egypt?
We know about pulmonary rehab in respiratory disease. Pulmonary rehab in elderly, you can tell us more about.
No, I'm talking about respiratory diseases in elderly.
Yes.
We suffer from having...
There is today, yani, there is mobile health apps which one can help to open, and enter patient weight, enter saturation, enter the diagnosis. He can help to open a class, yani a room for specific pulmonary rehabilitation program for him. In diseases like COPD, he can enter this classroom by some information related to his illness, and he can share. in home.
This is available in our practice.
But not يعني he will not take a mail, treadmill, or he will not take a bicycle. He will make simple pulmonary rehabilitation programs. Okay. Simple pulmonary rehabilitation program. No, not يعني do with machine. He will not do with machine.
Okay, thank you. Any questions? Okay. Thank you, Dr.
Thank you very
Heba.
much.
And I'm going to present the next speaker, دكتورة ريم صبري، أستاذ طب المسنين في جامعة عين شمس. Her talk is about optimizing medication management for the elderly.
بسم الله الرحمن الرحيم. اولا عايزه ارحب بكل التشير بيرسونز وزملائي الاعزاء، نورتونا. ولازم اقول طبعا ان انا سعيده جدا انا بشارك في مؤتمر قسم المسنين السنه دي ومؤتمر الكليه، لان بقى لي كام سنه كان لظروف صحيه بحضر وما بقدرش اشارك كسبيكر يعني. فالحمد لله السنه دي ان شاء الله اقدر اضيف حاجه او بمشاركتي يعني ان شاء الله. My topic will be about optimizing medication management in elderly population. As the baby boomer generation enter their senior years, البيبي بومرز جنريشن دولت سنة 2025 السنة دي، أقل حد فيهم عنده 61 سنة وأكبر واحد فيهم عنده 79 سنة. The population that needs most medications is expected to double by 2036, when 1 in 4 persons will be 65 or older. In recent years, applications and other digital tools have been implemented in healthcare systems to assist in drug management، زي ما الزملاء دكتورة هدى طارق كانت عملت demonstration في المحاضرة بتاعتها لبعض التولز اللي بنستعملها وحاجات available فعلا في الهيلث كير سيستم فور مونيتورنج، وده مهم فور ميديكيشن مانجمنت. Yet these new smart technologies can cause new challenges to prescribers اللي هم عندنا physicians, nurses, pharmacists and patients. Healthcare systems and staff need to ensure correct prescriptions and that patients take their medications as prescribed and report if any side effects occur, allergy, interaction. To achieve improved outcome for patients, human factors are as important as technology role. ودي جملة مهمة جدا، ان ما زال المان باور مهم جدا في الهيلث كير سيستم مع وجود الامبروفمنت في التكنولوجي، ولازم ان احنا ناخد ده في اعتبارنا. It is growing. Improving digital and IT systems for safer prescribing. يعني احنا الفيزيشنز بنبقى mainly البريسكرايبرز، فده مهم قوي. in many developed countries prescriptions are nowadays written mostly electronically. This allows them to be checked for safety related problems such as drug interaction, allergies, doses that are too high or doses that are too low, the appropriateness of dosing in patients with conditions such as chronic renal insufficiency. Poorly designed or implemented electronic medical records are widely implicated in clinician burnt out, which can also lead to poorer quality of health care, and this is very important. And as reported abroad, that the too much alarms from the electronic medical or health care records to the physician make them bored, getting bored and not responding properly. احنا ممكن نكون قابلنا حاجه زي كده في البراكتس، يعني مثلا الالارم في الاي سي يو ممكن مع ريبيتد الارم بنقول ممكن السيستم ديسكونكتد من البيشنت، ممكن كذا، فبيبقى في ريلاكتنس بعد كده من الفيزيشن من الريبيتد الارمز ان هو يبقى في ريسبونس appropriate response in time. فالsystems should be designed properly to achieve the better medication management. In the inpatient and outpatient setting, better approaches are needed to enable different specialties and all parts of the hospital team, including nursing, mentioned first, pharmacy, and physicians respectively, to be on the same page. كلهم على نفس المستوى regarding what the patient is taking. What is taking, what is the last dose, what is the route, and everything about the medication of the patient. Electronic medical records need to be implemented into practice, and the healthcare providers need to be educated how to use them in the medical process. The second point is improving education and the communication regarding prescribing. All prescribers must have a basic understanding of the medicines they prescribe to their patients. As a rule, both clinicians and patients tend to overestimate the benefit of the medications and underestimate the harm of this medication. In the near future, it is likely that artificial intelligence generated algorithms, including pharmacogenetics, and this is very important, pharmacogenetic variable, will also support this process. Two patients with the same diseases, with same condition, everything, and different in the pharmacogenetic, one can receive this medicine and the other cannot receive the same medicine. So in the future, there will be algorithms that taking into consideration the pharmacogenetic variable during the prescription. Teaching and education around the practicalities of prescribing, adherence, and polypharmacy need to be incorporated into the medical school curricula as a matter of routine. Mobile technologies have emerged as popular and potentially powerful tool to provide individualized support to change health behaviors. In 2019, 53% of the United States older adults owned a smartphone. And this is a good chance to access the elderly population in this community and to be useful in medication management or healthcare management, monitoring and medication. This creates a new opportunity to assess how well mobile applications can improve health behaviors and outcomes among older adults. Although there are more than 700 medication management applications, most haven't been evaluated, and none have exploited the potential of this media, limiting features to maintaining a medication list manually, bill reminder, and refill requests. Hybrid interventions, combine mobile applications with monitoring and triage to the health team based on patient need can empower and motivate patients and caregivers via tools that help identify and address ambivalence. Promote adaptive problem solving and provide quicker access to the health team and to address knowledge gaps. And the telemedicine that is Dr. Huda and my colleagues also mentioned in their lectures explained the role of the telemedicine that is a very good or excellent good communication between the patient caregiver with the healthcare system. So alhamdulillah, it is available and we can improve and make use and medication management is one of the best managed through the telemedicine, the available telemedicine in Egypt. Systematic reviews of web-based and hybrid interventions show that they increase patient empowerment, motivation, medication medication self-efficacy, and in some cases, patient outcomes. Again, elderly medication management is a critical aspect of senior health and care. Aging population, particularly susceptible to drug-related adverse events due to the change in the body structure, function, composition, and metabolic pathways. The importance of proper medication management cannot be overemphasized. Polypharmacy, it is a big issue in the geriatric population. The use of 5 or more medications is a common reality for geriatric patients. While medications play a vital role in maintaining their health, no treatment plan for a geriatric patient without a medication and well-being. Navigating a complex regimen can be challenging, potentially leading to medication errors, adverse drug reactions, and decreased adherence. Several factors are unique to geriatric patients that make them risk or contribute to the challenge of polypharmacy. Physiological changes, cognitive decline, multimorbidity, and functional limitations. The geriatric 5Ms framework for optimization of medication management. It is already these data or these domains are included in our geriatric comprehensive assessment tools, and we should highlight these issues in each patient because elderly population are diverse population and not everyone like the other. We have to tailor a management plan to each patient after assessing history examination and investigation to make a management plan that is suitable for this patient. So the 5Ms include medication. These include reviewing all medications. Medication reconciliation is very important. Considering effectiveness, potential interactions, dosage adjustment based on changing conditions of kidney, liver function, and utilizing available resources to help prescribing. Mobility, assess patient ability to manage their medication regimen. Can they open the pill bottles? Do they require assistance with injections or inhalers? Consider simplifying regimens or using assistive devices to improve adherence. Mind, evaluate cognitive function and identify any potential impairment that could impact medication management in this patient. Implement strategies like pill organizers, medication calendars, and clear written instructions to enhance understanding. Multimorbidity, address the complex interplay of multiple chronic conditions and associated medications. And prioritize medication for the most critical condition and consider de-prescribing or tapering medications as should. Last M is what matters most. إيه اللي أهم for the patient. Focus on the patient goals and priorities, the patient values and preferences in this issue. Involve them in medication discussion. After discussion with the patient and caregivers about the needed medications, and discuss with the patient and the caregiver about giving or not, and taking this into consideration. And tailor the regimen to their desired quality of life. Consider factors like treatment burden and potential side effects when making decisions. Social aspect is important in this also. Then what is the strategies for effective medication management? Medication reconciliation. It is a list of current medication, especially during patient transition from one level of care to another level, or within the same level of care from one place to another. Medication reconciliation accurately is very important. Regularly perform medication reconciliation at every patient encounter, especially during the transition. Communication and collaboration. Maintain open communication with the patient and his or her caregiver about their medications. Encourage them to ask questions and report any side effects, any allergies, any change in the clinical condition with the healthcare system. Patient education provides هي طبعا patient and caregiver education provide clear and concise education about medications, including administration instructions, potential side effects, storage information, utilize teach-back methods. When you ask the patient to explain back what instructions given to him for medication administration. Simplify regimen. When possible, simplify medication regimen by minimizing the number of medications, using a single dose for formulation, and considering long-acting medications for better compliance. Leverage technology. It comes from lever, الرفع يعني we give some effort and we gain much more effort than that is induced from the start. Technology, this is what is doing now. Explore medication adherence aids such as automated dispensing systems, and there is available systems that is alarming and dispensing medication and can be up to 3 months medication, up to 10 medications. This is with better compliance for elders. Medication reminders, it can be visual, auditory, or vibrating alarms to provide additional support to the patients. In addition, there are tools you can integrate into the electronic health care records to streamline medication management. For example, the robust e-prescribe solution. It is a software that enables writing an electronic prescription that is error-free, sending it directly to the pharmacy from the point of care. On the electronic medical records or health records, there is recorded or documented patient condition. يعني the assessment, the data gained from assessment, and including all the data, cognition, psychological, all the patient data beside the prescribing medication. Would provide clinical decision support to help you stay informed or of critical medication information for each patient, including allergy, any history of drug allergy, interaction, full medication history, and more. With this information readily accessible as a touch of button, it can save you a significant amount of time, save much time, while adding an extra layer of protection. The cost of this e-prescribe software is $100 every setup. We should consider the cost of this technology or smart applications into our plan. By implementing a multifaceted approach that considers the geriatric 5M framework, you can optimize medication management for your geriatric patient, while each patient has unique requirements, challenges, and risk to remain mindful of and implementing these strategies and technical technological recommendations that can help alleviate some of these risks. Telemedicine, I have to talk of telemedicine, so I put this in my lecture, but I am not in details, but it has a major role in our country in medication management. Telemedicine has emerged as a vital tool in managing the healthcare needs of seniors, particularly when it comes to medication management. This technology enables seniors to consult with healthcare providers remotely, making it easier to address medication concerns and get prescription refilled. Such virtual consultations are especially beneficial for seniors who may have mobility challenges or live in areas with limited access to the healthcare facilities. Regular telemedicine check-ins can help in proper medication adherence, timely dosage adjustment and medication adherence, timed dosage adjustment, and identification of potential side effects, adverse effects, or drug interactions. Moreover, telemedicine can be instrumental in managing other aspects of senior health, such as mental health support and home exercise guidance, and this will help in the medication management, by improving the mental health and the patient fitness. I'm trying to illustrate in last few slides. This is the patient with the medication dispensers that is giving the dispenser, giving information to the medical staff, medication monitoring server, and system administrators. The data about the medication state, the device state, the system setting, and the outgoing data from the staff to the dispenser, to the patient through the dispenser about the medication schedule, update, system setting management, embedded programs management, operational errors management. This is example of a Wi-Fi automated bill dispenser. It costs $300. It is operated through the mobile, through the Wi-Fi. It is giving alarm and dispensing the medications in time. Alarm vibrating watch. As we said, the alarm can be visual, auditory, or vibration. This is a talking reminder clock. It costs $30. Closed loop medication management. This is substitution of any manual step by a computerized one, intelligent one. It is a closed loop medication management for avoiding medication errors. It starts by, it is a circle. It is a circle started by a computerized making informed care decision by the physician, then computerized order entry, clinical decision support tools, drug interactions or allergy or كده should revise this prescription from the physician. Then the physician give eligible complete order, goes to the pharmacy, then review and verify order in the pharmacy, and upon this, the pharmacy will dispense barcoded unit dose medication. وunit dose يعني جرعة بجرعة. يعني مثلا لو في ميديكيشن بيتاخد 3 times per day فهو بيدي كل مرة تابلت. كل 8 ساعات تابلت. فدي اسمها unit dose. وبيطلع اليونت دوز دي بالباركود بتاع العيان. Then store medication secure storage في automated dispensing cabinet and medication cards. انا هحطها في السلايد اللي بعد كده or work station on wheels موجوده برضو في النكست سلايد. بعد الستورج of medication securely, this storage can be in the inpatient pharmacy, the outpatient pharmacy. Assess patient prior to administration للمedication. We have to assess the patient before. Then scan the patient and medication barcodes prior to administration عشان اعرف ان الميديكيشن ان اليونت دوز دي بتاعت العيان ده، ان الدواء صح والمريض صح والروت صح. فاحنا we have to check the 7 rights. It is the right patient, the right drug, the right dose, the right time, and the right route, and documentation and reason. After that, administer medication to the patient safely. Then medication administration recorded electronically. This is by the nurse mostly. Then monitor patient and document as appropriate. أي feedback بقى after administration للميديكيشن اتغير في الكلينيكال كونديشن، أي حاجة حصلت allergy أو كده should be monitored and recorded electronically to the system to be given in consideration to be for the next prescription, revise and consider the new data. لسه عايزة اللي قبلها مش راضي. Last slide. Also, about the intelligent closed loop medication management system. This is the order entry started by the supplier order entry, then the order goes to the warehouse المخزن، بعد كده للاوت بيشنت فارماسي او الان بيشنت فارماسي او الاوبريتنج روم فارماسي where to be stored securely there in electronic cabinet، وفي اللي هي الكارت اون ويل في اللي هي تحت هنا دي. This closed loop prevented many medications error, and it is still evolving and growing issue. Thank you. I want to ensure about that the available devices, applications, algorithms should be authorized. We should consider its cost and should be monitored before use. If you enter to the Google store, you can find many applications that can measure blood pressure, blood glucose, and we don't know what is the accuracy of these applications and should take this into consideration. Thank you.
شكرا جزيلا دكتورة ريم. Thanks so much for your informative lecture. Any questions? Thanks so much. شكرا دكتورة ريم. I would like to invite دكتورة سامية عبد الرحمن for the next talk titled New Model to Predicting Fracture Risk in Elderly Patients. دكتورة سامية, our professor of geriatric medicine at Ain Shams University.
صباح الخير عليكم جميعا، وشكرا على دعوتي لان انا اعرض عليكم التول بتاعتنا النهارده في المؤتمر بتاع الاسم. احنا ان شاء الله يعني حابه اعمل انترودكشن الاول على الاورثو جيرياتريك تيم. احنا we worked to make innovative tools for assessment of osteoporosis, osteoporotic fractures in elderly population. We have developed a new model for prediction of fractures, fracture risk in elderly females. We are going to make a similar tool for elderly males. And then our plan is to have a platform that you can enter the data of your patient and you can understand how his fracture risk is at and manage accordingly. Why are we doing this? We all know that there are predictive models that are made worldwide, like FRAX model for prediction of 10 years risk of fractures in elderly patients. And we can rely on something like that. But unfortunately, we don't have a FRAX model for the Egyptian population. That is the first problem. We started with females because females are at higher risk of osteoporosis and also at higher risk of osteoporotic fractures. Also, fragility fractures in elderly have a magnificent effect on their health and their outcomes. They can cause functional decline, reduce the quality of life, and a change of the living arrangement, and of course, mortality. In order to do something like that, we have to understand the statistics and the data of the Egyptian population regarding osteoporosis and fragility fractures. And unfortunately, we don't have that as well. So we decided to start with our center, مستشفى الشهيد أحمد شوقي. We started by gathering data about our center. الحقيقة إن إحنا لقينا الأرقام يعني مهولة شوية. الأرقام دي هي الانيوال numbers بتاعتنا. Around 44k individuals بيجوا ER for orthopedic problems alone. Among them 70% are female, around 31k. 30% of those suffer hip fractures, around 1K. And of those with hip fractures, about 10% suffer hidden vertebral fractures. So the numbers are huge. How to predict those at risk? This is the question we wanted to answer. We could use the FRAX model. But I want you to look at the FRAX model and say, is it all inclusive? Can it predict the fracture risk accurately for all patients? The risk factors listed in the FRAX model are age, sex, weight, height, measured body mass index, previous fractures, parental history of fractures, smoking, glucocorticoids, rheumatoid arthritis, secondary osteoporosis, and alcohol, 3 or more units per day. And of course, the body mass, the bone mineral density of the patient. Okay? These are important risk factors and should be considered, but they are not the only risk factors. And that is why FRAX has developed another tool, which is the FRAX Plus. The FRAX Plus, they have the secondary osteoporosis causes being divided into different points, like recency of osteoporotic fracture, high exposure to oral glucocorticoids, type 2 diabetes mellitus, اللمبر سباين بون ميرال density، لان احنا كنا الاول بناخد الفيمورال بس فزودنا اللمبر سباين، الترابيكولار بون سكور، الفولز هيستوري and hip axis length. Okay, is that enough? Does this include all osteoporosis risk factors and all fracture risk factors? Of course not. When you look at the risk factors for osteoporosis and fractures, you can see age, which is included in the FRAX model, sex included as well, menopause is not included, body mass index is included, ethnicity is included, maternal history of fracture is included, diet is not included, smoking is included, alcohol is included, steroids are included, liver and kidney disease are not included. Also, rheumatoid arthritis is included, anti-epileptics are not, previous history of fracture is included, thyroid disease is not, diabetes is included in the FRAX Plus model, eating disorders are not included, drugs, parathyroid disease, vitamin D deficiency, malabsorption, COPD, cancer, all these risk factors are not included in the FRAX or the FRAX Plus models. According to long-term glucocorticoids, we said that it's included. Certain steroid hormones like progesterone or LH-releasing hormone agonists, hormone deprivation therapy, proton pump inhibitors, certain antidiabetics, antidepressants, anxiolytics, sedatives, etc., etc. Many medications are not included in the FRAX or the FRAX Plus models. Thyroid hormone, aromatase inhibitors, chemotherapy agents, antipsychotics, anticonvulsants, antiepileptics, anticoagulation, and the list goes on. Do we have the luxury of time? We can take the simple route and make another FRAX model for the Egyptian population, but we have to wait for 10 years follow-up for patients to make this model because it's a 10-year prediction model, and we can't afford the time. So we have to do another model for 1 year prediction of fractures, and then while we're going with the time, we can make the 10-year assessment later on. So our aim was to develop a tool that can be applied to the Egyptian population and can predict 1 year risk of fractures, especially that the findings in our model were huge, more than the previous numbers. So we looked at 5683 records. 3K of them were males, so they were excluded. 220 had malignancy and were excluded as well. 613 refused to participate. 685 dropped from follow-up. 433 were deceased. Those are the data of 1 year admissions at our hospital. The remaining were 168. We took 170 of those female patients, and we followed these patients for 1 year. We had the full medical record of these patients obtained. We reviewed fracture history during the year of follow-up, and to make sure that we did not miss anything, we had the patient come for a radiological survey of hidden vertebral fractures. All known risk factors were taken into account, and the weight of every risk factor was measured. So the results showed that 37.1 had fractures. 37.1. That's a huge number. It's more than 1/3 of the patient admitted in our hospital after 1 year had fractures. 24% had hidden vertebral fractures. 6.5% had non-vertebral fractures. And 6.5 had more than one fracture. The numbers are alarming. We had a univariate analysis to identify significant risk factors as our first step, then multivariate analysis to assert the final risk factors, logistic scoring system to assign risk factor indices based on multivariate regression results, additive scoring system to predict fragility fracture incidence in individuals. Sensitivity and specificity of our tool was 96.83 and 86.9 respectively. So we found the most prominent risk factors were glucocorticoid usage, premature menopause, chronic liver disease, thyroid medications, regular vitamin D supplementation, or the lack of, and regular calcium supplementation. These were the factors that were significant. In the univariate analysis, body mass index, glucocorticoids, premature menopause, chronic liver disease, thyroid, regular vitamin D supplementation, and calcium supplementation, and the 10-year risk factor, risk of fracture using the FRAX without the body mass bone mineral density, and calcaneal T-score of less than or equal to -2. In the multivariate, the remaining factors were body mass index, thyroid medications, glucocorticoids use, regular vitamin D and calcium vitamin D supplementation, and the FRAX score and calcaneal T scores. So finally, our tool is available. The model we used, this is the data of the logistic scores and the additive scores. Here are the logistic scores of the significant risk factors and the additive scores. And you can put the data and find your risk in 1 year. And we are this is the sensitivity and specificity data. We are intending to make a platform for our hospital to be readily used by our physicians in the clinic, so they can enter the patient data and get the results of the 1 year risk of fractures in our patients. We can have an application made for that later on, but this is our preliminary data, and we are adding to the data. The male data are soon to be available as well. And we hope this helps in the reduction of fracture risk in our populations. Thank you.
Thanks a lot, Dr. Samia. It is a very good research, and I hope it's applicable in the practice إن شاء الله. ولو محتاجة أي حاجة بقى في الدعم بالنسبة للمستشفى. ان شاء الله باذن الله. Any
أكيد إن شاء
questions؟
الله.
مفيش حد. Thanks a lot. We are going to have our break now. هنرجع على الساعة 1:30 بإذن الله. I would like to thank you all. Thank you. شكرا.